Hi, everyone. Welcome to a Saturday VMR for specifically the management reasoning VMR. Thank you so much for joining us. And depending on where you are, good morning, good afternoon, good evening. Maybe you see a new face today. My name is Jazz. For those who don't know me yet, I'm a former chief resident at the University of Rochester. And I'll be starting my job as a hospitalist in September shortly. So I have the great joy and pleasure to co-host today with Shema. Shema, do you want to say hello?
Hello, hi, I'm Shema, and I'm so honored that I can join Jazz on this management reasoning VMR. When I told Yusuf that I would like to have a management reasoning on hypertension and so on, he told me, "You want to work with Jazz?" I said immediately, yes.
You guys are too kind. So we have like Shema said that we do have a hypertension workshop or VMR today. It will be focusing on resistant hypertension and also sheds a little bit light on inpatient hypertension as well. So something that I personally feel is high yield, not just for testing purposes, but also in clinical practice as well. And we're going to start off with some cases, and I'll give a couple seconds for our team to get the whiteboard up. And just while that's happening, I'm just going to kind of go over. So these cases that I selected today were patients that I've seen either in the clinical setting, either like in the outpatient clinic or inpatient. So these are real cases that I felt like would be great learning cases for everybody. And then what we're going to do is we're going to do breakout rooms for 2 out of the 3 cases. And the third case we're going to discuss as a team, as a big collaborative group. And then the other thing that we will be doing is, at least I'll be doing, is I'll be going from breakout room to breakout room to just copy and paste the case vignette, just so that for those who may have forgotten some details, you'll have that refreshed. Any questions or concerns off the bat? You're too kind, Deborah. It is my first time. Okay, let's share our screen then. Also, I'm seeing a new face here today, Diego. Greetings from Mexico. If you're able to unmute and kind of introduce yourself, that would be awesome. I don't think I've seen you here before.
Yes, it's my first time. I'm Diego González, and I'm from Mexico City. I'm 23 years old, and I'm on my 4th grade of medical school.
Wow, that's awesome. Thank you so much, Diego, for joining. Is this your first time ever?
Yes, it is.
Wow. Okay, so big expectations. Hopefully you enjoyed today's session.
Okay, I think then we can start with the first case. So as the first case, we have a 45-year-old male with a history of hypertension who presents to the clinic for a blood pressure follow-up. The patient has been taking antihypertensive medications for the past 2 years, but his blood pressure has remained uncontrolled despite adherence to the prescribed regimen, so ACE inhibitor and recently prescribed hydrochlorothiazide. In office, blood pressure is 160 to 100, and the rest of his exam was normal. The basic metabolic panel was normal, except for a hypokalemia of 3.1. So what is your assessment of this patient, and what further workup would you do, and how would you treat this patient's hypertension?
Thank you, Shema. So we can break up into breakout rooms. Sarah, are we good for that? Yep, no worries. So basically just so while Sarah's setting that up, I'm going to explain. We all have probably about 5 minutes per breakout room. And I want you guys to all three of the 3 or 4 groups, however we're going to create. I want you all to think about the assessment of this patient, further workup, and then how would you treat this blood pressure in terms of agents. And when you all return, though, I'm going to collectively pick one group to be assigned assessment of the patient, and then the second group to be assigned the further workup, and then the third group to be assigned treatment of hypertension. I'm not going to assign those now. That's why I want you all to work on all 3 of those questions.
And all the rooms should be open, so have fun with your discussions.
See you in a bit. All right, welcome back, everyone. So I think some people are going to be slowly coming back in. We'll get started into the questions that we wanted you to go over. So, like I said, all 4 groups were tasked to all 3 questions. What is your assessment of this patient? What would you want to do further workup? And then how would you treat this hypertension? So group 1, I think I'm going to combine group 1 and group 2 just because of the participants. So group 1 is Leah, and then group 2 is the group with Alex. So can group 1 or 2, if they can unmute and can I explain what your assessment of this patient was?
Yeah, I can go for group 1. So we were thinking about how well, at first check whether the patient was compliant with the medication, but if everything was fine there, then also consider maybe there's a secondary cause of hypertension, as there is no response to treatment for this patient, despite the medication they are on. So I guess our main point for the assessment is not just limited to what information we have here, but go back and do further assessment, get some more history, do some clinical exam. Maybe we have stigmata for secondary causes of hypertension.
Perfect. Alex, your group?
Yeah, I was also in there. I think Noah could add a little bit more. He was teaching us a couple of things in our breakout rooms. Noah, do you want to say?
You're too kind. I was only answering your questions. So in our group, we discussed a little bit about the possible etiology of secondary hypertension, which could explain the low potassium. That is hyperaldosteronism. We discussed how we could get plasma renin and plasma aldosterone level to screen for this entity.
That's perfect, Noah. Great job. So group 3, I believe there's one with Mohammed, Hutang, and Yusuf. If you guys want to comment on further workup, what would you do for this patient if you were seeing this patient in front of you in clinic?
Hello, so I could go ahead. So we talked about basically first reviewing the patient's meds and making sure that he's compliant, like the other group mentioned, addressing some basically some maybe hidden agenda of the patient, why the patient maybe is not taking the drug, or maybe there's some social issues, making sure there's no like drug-drug interaction or any just making sure that we rule out sort of the meds, and then basically looking at how many antihypertensives does the patient used, because as we can see in the case so far, there are 2 antihypertensive medications he's on, and despite that his BP is still uncontrolled. And we were thinking with the new onset hyperkalemia, whether it's like a side effect of the medication or like something related to some kind of hyperaldosteronism state with the resistant BP. I'm not sure if I can call it resistant BP because I don't know how many drugs were the patient using. But yeah, that's so we were thinking of screening the patient for basically a hyperaldosteronism.
Perfect. And then group 4, it's with Aisha and Deborah, Hans, and Julia. What would you do next in terms of prescription? What would you prescribe next as a medication, or would you prescribe anything here?
I think so. What we discussed was that we could think about if he is taking his medication, but hydrochlorothiazide does cause hypokalemia. So that could explain that, yes, he is taking his medication. So I think I would rule that out. But next I would, we could try that. We could optimize his dose for hydrochlorothiazide if possible, and then move on to diuretics, loop diuretics, which can be added, or we can add, and then depending on the cause of the secondary hypertension. So if it's hyperaldosteronism, we can consider, spironolactone, and just depending on the causes. If it's, we were also thinking of renal stenosis in this patient as the causes. So if that's one of the causes, then we can first of all control the blood pressure, and then go to more invasive procedures, surgical revascularization for the stenosis as well. Yeah.
Great thought, really great thoughts, Aisha. So let's dissect this case a little further. So this patient of mine, this is actually my patient that I actually saw in clinic for the last 4 years. And when he came to me at this visit, I was also in the similar framework that you guys had. Is this a patient that may have underlying primary hyperaldo versus is this just he's not maxed out on his antihypertensive medications yet? So I actually, at this visit, the one that you guys are seeing right now, I actually started him on amlodipine to give him 3 antihypertensive medications and asked him to come back in a couple of months. And in repeat of his BMP in a couple of months, his potassium dropped down to 2.8. And his blood pressure was basically unchanged, even despite 10 milligrams of amlodipine. So that is when, you know, I did a renin and aldo level. His renin was suppressed and his aldo was, I think it was like 28 or 30, something like that. It was pretty high. So the answer eventually was primary hyperaldo, but the reason why I made this case vague is I wanted exactly what you guys all said, because I think Mohammed mentioned it. At this vignette right now, he does not meet the definition of resistant hypertension, but sometimes these patients will come to you with clues earlier on that may make you think that, there might be something else going on. And this is where my next side pearl is. Most patients with primary hyperaldosteronism will have a normal potassium level. In fact, less than 40% of patients will have hypokalemia for those who have primary hyperaldo. However, a clue that this patient may have primary hyperaldo is a pretty significant drop in potassium after starting a thiazide diuretic. In fact, this drop can be anywhere between 10 to 50%. And basically, you may say, well, you may argue that, well, thiazide can cause hypokalemia. From clinical practice, thiazides typically don't drop your potassium from like 0.2 to more than 0.2 to 0.5. If there's more than that, you may want to ask yourself, is there something else going on? So one of the pearls that I learned from one of my nephrology colleagues is that if you have a substantial drop, a significant drop, this patient's previous potassium levels were 4.5, 4.4, 4.3, 4.6, and then all of a sudden went to 3.1, 2.8 as soon as they started with thiazide. And so then after his renin and aldo level came back, we ordered an adrenal CT, which showed no mass, which is actually not uncommon. Majority of patients with primary hyperaldosteronism will not have a mass. But it is always crucial to order that imaging study. And the reasoning behind that is CONN syndrome, CONN syndrome. And Conn syndrome, if you do have an adrenal mass that is releasing aldosterone, if you remove that mass, majority of these patients can come off all of their medications. So it is crucial to consider imaging. And you guys all nailed it with in terms of medications that would respond to primary hyperaldo. It would be a mineralocorticoid receptor antagonist, such as Aisha mentioned, like spironolactone. In terms of the test itself, renin and aldo levels, most nephrologists that I've spoken to love this test. It's great. There are certain things that can interfere with it, though. I know we've notoriously has been taught that the ACE or ARB needs to be held. In fact, actually, that's not true anymore. Most recent studies have shown that you can actually still order a renin and aldo level, and it doesn't necessarily have a patient already being on an ACE or ARB necessarily does not interfere as well as we once thought it did. One thing I will say though is pregnant patients, and if patients are already on a spironolactone for other reasons, that will interfere with the studies. And what I would recommend in that is if the patient is already on spironolactone, I would ask the patient to hold it for 4 to 6 weeks before testing this patient. That's a lot of information. And is there any questions or clarifications that I can provide? Okay, I'll take silence as a good thing. And so Shema, I think we might be ready for case number 2. Oh, I think we have one question. Sorry, 1 second. Yeah, so that's a great question, Ala. So the hypokalemia rule, so with loops, so when you're comparing loops to thiazides are way more of a potent like a potassium wasting diuretic than a loop. You can see it. So in general, primary hyperaldosteronism patients are more sensitive to hypokalemia. So for example, if you eat a high salt diet, patients with primary hyperaldosteronism are going to have more hypokalemia than a normal individual. Patients who have primary hyperaldo and are also on a loop will probably can have some hypokalemia, but you will see the greatest drop in potassium from a thiazide. I hope that helps answers your question.
Okay, then I think we can start with case number 2. So for case number 2, we have a 38-year-old female presenting with episodic headaches, palpitations, and diaphoresis. And also she has fever and confusion. Her temperature is 41 degrees Celsius, blood pressure 230/135, a heart rate of 130, and her respiratory rate was normal. An EKG revealed sinus tachycardia. Her serum creatinine is 2.4 with a baseline of 1. And again, we have the same questions about what is the assessment of this patient, what further workup would you do, and how would you treat this hypertension?
All right, and all the breakout rooms should be open.
Everyone, welcome back. I'll give you guys a couple seconds as we get the whiteboard back up. And I think if one thing you might have noticed from this case is this one probably can have a little bit more of a longer differential. So let's reverse the order. Let's do groups 3 and 4 to share their assessments. So that would be group 4 is with Aisha and Deborah and Hans, and then group 3 is with Diego, Huting, and Mohammed. What was your assessment of this patient?
I can go. So we were thinking our primary diagnosis, differential diagnosis would be PHEO in this patient, pheochromocytoma. And for her, or it could be a thyroid storm as well. So we would need to do imaging. We'd need to do labs to look for catecholamines in urine catecholamines, and we would need to do lab imaging to look at the adrenals and also the thyroid as well.
Great. And then next group for assessment. I think that would be Mohammed's group.
All right, so I can go. So we kind of talked over the same things that Aisha mentioned as well, and we were also considering pheochromocytoma from the get-go, but we tried our best to avoid our cognitive bias and tried to complete everything up and before saying it's pheo, and especially with the context of fevers and confusion. We were trying to relate how this could be related, or is it something else going on at the same time? Yeah, and we wanted to take some quick HNP, see if the patient has been having like intermittent blood pressure, elevated blood pressure readings, which could pinpoint again to pheo. But yeah, that's where we're thoughts.
Great job. Group 2, in terms of what would you do? I'm going to add an extra question though. How would you triage this patient if this came into the clinic? And then what would you do in terms of workup? So this is Noah's group with Alex, Maria, and Reshma.
So with such a rich discussion about the differential, we didn't quite get to all the components of management. But I think the anybody jump in, cut me off if you guys disagree from our group. I think if the patient were at our clinic, I think maybe our first step would be to send the patient to the emergency department. And then maybe once the patient got there, we talked a little bit about looking for both triggers of some of these more rare diagnoses like hyperthyroidism and like pheo, looking for or triggers and or the like separate diagnoses themselves. Like maybe if this patient was baseline hypertensive and was septic but didn't quite develop septic shock, so maybe their baseline hypertension, their hypertension just got worse in the context of acute illness or pain. So looking for sepsis both in its own right and also as a trigger of something like hyperthyroidism or a flare of the patient's existing pheo. And then once we did that, potentially starting empiric antibiotics for the moment, and then sending off things like a TSH and a free T4 to look for hyperthyroidism and potentially getting some adrenal imaging like everybody else had said.
Beautiful. And then so for group 1, Leah's group, how would you manage this patient? I know Alex already said that he'll send to the ED, but if this is a pheo or even let's say hyperthyroidism, did you guys talk about what you would want to do to treat this patient's hypertension?
Lara had some great thoughts on the height of the hypertension and the consequences for management. If you want to unmute and share.
I basically just said that considering her confusion and either AKI on CKD or just an AKI, we definitely meet the criteria of end organ damage. And so we would need to treat it as an hypertensive emergency and bringing her down by 25% in the first hour. And so we usually go by either esmolol or labetalol IV. But I know that also some are from Europe joining, and Leah mentioned they are using Urapidil, which we are not using here.
Thank you, Laura, for your input. That was excellent. So Shema has more on that towards the end. So thank you for sharing the different styles or different countries and how they manage hypertension. So let's dissect this case a little bit further. So believe it or not, I actually saw this patient in clinic. I was doing walk-in clinic and this patient showed up just like this. So exactly what Alex said. I said, yeah, you need to go to the ED as soon as possible. And before I sent you to the ED, EKG was within normal limits, but her creatinine was elevated from baseline, so she was taking a toll. Workup in the ED and the hospitalization showed a normal TSH. They also got a serum beta HCG, which always keep in mind for patients who are within childbearing age, you have to consider pregnancy-related complications, for example, HELP or even preeclampsia. And keep in mind, 4 to 6 weeks after postpartum, you can still develop preeclampsia. You know, I've seen a case where a patient who was 4 weeks out of pregnancy, so postpartum, was being treated for community-acquired pneumonia, but actually was in preeclampsia. So it can fool you pretty quickly. So this patient eventually had plasma and urine metnephrines that came back like skyrocket off the charts. Actually in this patient, and I'll talk about this in my teaching points, but so this patient was actually diagnosed with a paraganglioma, and we'll talk about that in a second. The management in the ED and on the hospital floor was phentolamine, and they started nicardipine as well. The goal, like Laura mentioned, was to reduce the systolic blood pressure in the first hour to roughly around less than 140, depending on how high it was initially. But you would actually avoid beta blockers in this situation. Anytime you're ever suspecting a FEO or a paraganglioma, you have to avoid beta blockers as the initial therapy because it can lead to unopposed alpha adrenergic activity. So typically depending on your institution, your go-to may be labetalol for hypertensive emergencies. In any situation where you have a slight doubt that this might be a FEO or a paraganglioma, you kind of probably want to hold off on the beta blocker. So what is a FEO or a paraganglioma? It's just basically release of excess catecholamines. And what is the difference between those two? So a FEO is within the adrenal gland. A paraganglioma is actually extra adrenal gland. It's outside of the adrenal gland. And in this patient, it actually was an interesting but also a sad case as well. It was a paraganglioma that was encased around her aortic arch. So the surgeons basically did not feel very comfortable, obviously, to operate on it. So for the last now like 4 years, she's been on maximal hypertensive therapy to control her blood pressure rather than it being excised and her being well controlled. Another side pearl with patients with paragangliomas or FEOs is that they can present with orthostatic hypotension or syncope. And the mechanism behind this is that these tumors, they're intermittent and cyclic, meaning they release oodles of this adrenaline and these metnephrines, and it gets into your bloodstream and it raises your blood pressure. And then what ends up happening is these tumors then, because they're intermittent, stop releasing these hormones, and the blood pressure has a significant drop, leading to decreased blood flow to the brain, resulting into that syncopal episode. In terms of how we test for these patients, the fractionated metnephrines, it is the first step. I just want to caveat though that it is only diagnostic if it is greater than 2 times of the upper limit of normal. Mild elevations can actually occur with a lot of different medications, one of them being tricyclic antidepressants, antipsychotic agents, SSRIs. And the other one that you don't want to forget about is acute illnesses. But that makes sense though, right? Fight or flight. And when you're having a stressful response like an acute illness, you're going to have the release of cortisol and adrenaline, and that can lead to a rise in your plasma and your metnephrines. CP, if it's non-contrast, the way you want to look at it is the Hounsfield units. So if it's less than 10 Hounsfield units, you can confidently say that it's probably not a FEO. Whereas greater than 10 Hounsfield units on the CT report could be a FEO, but you would have to combine that with the test results as well. Yes, Rashma, yes, it is imaging for a paraganglioma. Any questions or clarifications I can provide for case number 2? All right. In that case, then let's get on to case number 3 then. So this is where I'll stay as a group. And I'll let Shema take over.
Okay, so as case number 3, we have a 68-year-old male with hypertension presenting with nausea and vomiting for the last 2 days. The blood pressure is 200/130. The home meds include lisinopril 40 milligrams, amlodipine 10 milligrams, and hydrochlorothiazide 12.5 milligrams daily. He has been having a difficult time adhering to his medications. And I would now turn over to Jazz.
Perfect. So this one, feel free to unmute and answer the questions, or if you feel more comfortable, place them in the chat, and that'll be great. So the first question I want to ask is, just hearing this vignette, what additional history and exam data would you all want to collect from this patient?
And does he have in general difficulties to adhere to his medication, or just since he started to vomit 2 days ago?
It's a great question. In general, he is a patient that has 2 jobs, and it's been a very difficult time for him to remember taking his meds.
And does he measure his blood pressure at home?
He does measure his blood pressure when he remembers to, and he averages maybe like once a week, and it's high at home as well.
Okay, thank you.
You're welcome. All right, so those are all good questions. So basically, this patient, when we asked additional history and data, reported a headache, but denied blurry vision, chest pain, dyspnea, numbness or weakness or confusion. There was no focal neurological deficits on exam. So I saw some of you mentioning basically intracranial hemorrhage. So outside of a headache, denied all sorts of other symptoms. So my next question to the group is, what investigations would you order? Okay, so some couple people in the chat would want a non-contrast CT. Noah wants some CBC, CMP, EKG. Okay. All right. All right, so basically we did an EKG which showed no ischemic changes. Troponins basically were unremarkable or adynamic, and creatinine was at baseline. We also did get a chest x-ray to see if there was any pulmonary edema, secondary to his hypertension, no focal infiltrates, and a head CT was normal. So then the next question is going to be a poll question. So let me just pull up the poll here. You all should be able to see it. And the question is, for those who will be watching on YouTube, do you think this patient has hypertensive emergency? Wow, the results are pretty split here. It's actually pretty interesting. I'll give another 5 seconds. Reshma does not have blurry vision. Yes, sorry, Maria. chest X-ray, CT, EKG, blood work were all normal. Stools, he's regular, once a day, not constipated. All right, so I'm going to end the poll. So the results were basically 33%, 33%, 33%. Split down the middle. I'm going to share these results so you guys can see it. And then, all right, so the answer actually was no. This patient does not have hypertensive emergency. And hopefully after today's VMR, this can become a little bit more of a clear understanding. Now, I also want to acknowledge this is very hard. You have a patient that's having nausea and vomiting, and complaining of a headache. The first thing we think of is a blood pressure this high, 200 over 130, and he's having some type of symptoms. This must be a hypertensive emergency, right? But I think one thing is that hypertensive emergency is defined. We'll actually go into the definitions later, so I'm not going to take Shaima's spotlight there. But basically, in this situation, the answer is no. He does not have a hypertensive emergency, and we'll get to that in a second. So I don't want to take away Shaima's spotlight there. So I'm going to move on to the next poll question. Okay, and that is for those on YouTube. What would you do for this patient? And you have 4 options. All right, I'm going to end the poll. I'm going to share the results. So 54% of you said control the nausea, restart home meds, whereas 38% of you said send patient to the ED for IV antihypertensive medications. So I think in this situation, the answer actually was control the nausea, restart home meds with the goal of lowering blood pressure over days and not during hours. And the other thing is, so very quickly, I'm going to talk about the management behind this. Is this patient has history of blood pressure, high blood pressure. Therefore, there's a good chance he was probably running 200 over 130, not just in our office, but for weeks, maybe even months, depending on when his last follow-up was. Therefore, starting him on IV antihypertensives or sending him to the hospital to lower his blood pressure dramatically would actually cause more harm than actually good, because his whole body, his whole autonomic nervous system is actually adapted to this high blood pressure. So what you would do in this situation is monitor the patient. You can send him to the ED to get a CT scan. Typically in our clinic, we would do a stat CT if we really were worried. But with non-focal changes, I think it's also reasonable to also say, here's some Zofran, see if the nausea gets better, and recheck your blood pressure at home, and especially how you respond from the antihypertensive medications. In this situation, this is actually a very common presentation we see in the clinical aspect of things. And what we would do in this case would bring the patient back in a couple of days in clinic to see how they're doing for a reevaluation. One of the most utilized ED visits is primary care physicians sending patients to the ED for a blood pressure that's like 180, 200. But really, the ED doesn't really, other than telling them to restart the home medications, there's really not much to do other than maybe getting a CT head if they're having focal symptoms. And what was causing the nausea and headache? So I think you guys are all asking that question. So high blood pressure can, in fact, just by the secondary effects of high blood pressure, can lead to that nausea and headaches. So if basically you control the blood pressure to a more sustainable or more suitable level for that patient, and their headaches go away. I had a couple of patients that every time their blood pressure would hit 200 systolic, would get a headache. But as soon as it comes down to 170, 180, they'll feel better. Now, I know if my blood pressure was 180, I would get a headache. But for others, because of this long-term adaptation, their threshold gets a little bit higher over time. So basically, I just wanted to give the mic to Shema now, because we wanted to quickly talk about end organ damage scenarios. So what are the end organ damage scenarios?
Yeah, so for the end organ damage in terms of this case, Jess came up with an amazing mnemonic to remember these. It's called BARC. B standing for brain. So think of something like hypertensive encephalopathy that can present with cerebral edema or any kind of ischemic hemorrhagic stroke, or what was also mentioned in the chat, something like PRESS. And then the A from BARC is standing for artery. So something like aortic dissection. You can have the R that is standing for retina. So any something like acute hypertensive retinopathy that can present with papillary edema, flame, hemorrhages. The K standing for kidney. So hypertensive emergency can present with a TMA, for example, with AKI or acute hypertensive nephrosclerosis. And the H from BARC is standing for something like you can have heart failure, decompensated heart failure, flash pulmonary edema, myocardial infarction. Yeah.
Great, Shema. Thank you for sharing that. I think we're going to be out of time to discuss the different types of how to manage different types of end organ damage. I will quickly share that, but I unfortunately won't be able to go into details. So one end organ damage, like Shema discussed, was the heart, right? So if you have an acute LV failure with pulmonary edema, think about nitroglycerin and IV diuresis to reduce both the preload and the afterload. And you want to reduce by 10 to 25% in the first hour. And you want to avoid beta blockers in this situation as well, because if that heart failure is new and it's decompensated, it actually can precipitate cardiogenic shock. For acute ischemic strokes, that's the one where you want to be a little bit more cautious. So if their blood pressure is less than 220 over 120 and they're presenting with a stroke, you can give them some permissive hypertension. So you don't have to necessarily lower their blood pressure you don't have to lower it pretty aggressively. The rough framework is 15% in the first 24 hours. And for this stroke, you could do either labetalol or nicardipine. For aortic dissection, you can either do labetalol or esmolol. Esmolol is wonderful because it's short acting and you can titrate it pretty readily. And you want to have a target heart rate of 60 with the beta blocker, and then start nitroprusside, and you want to lower the blood pressure to less than 120 as soon as possible. This is the only circumstance where you may risk a stroke because you lower the blood pressure too fast, but the off chance that the aorta ruptures, it's worth, in that case, the benefit outweighs the risk. Lastly, for acute renal failure, you want to reduce the blood pressure 10 to 25% in the first hour. The preferred agents could be nicardipine or fendelopam. What I learned about fendelopam is that actually increases perfusion to the kidneys while reducing the blood pressure as well. Shayla, I'm going to turn it back over to you.
Okay, so coming back to the management in Germany. So as Jess mentioned, hypertensive emergency, or what we already talked about, there's a different kind of management in Germany because we have some limited availability of several medications in Germany, like common medications like labetalol or nicardipine are not available in Germany. So first line being used is urapidil IV. Urapidil is an alpha-1 blocker, and usually we get a bolus injection and then a continuous infusion. And urapidil can also be used in off-label in hypertensive emergency in pregnancy. It is also being used as initial treatment in FEO crisis. And in acute coronary syndrome with cardiogenic edema, we can use nitroglycerin and loop diuretics in order to decrease the preload. And if we have therapy-resistant hypertensive emergency, in inpatient setting, you can use enalaprilat, which is an ACE inhibitor, or you can use esmolol. It's a beta blocker with a short half-life and it's well controllable. And in worst case scenario, nitroprusside can also be used. The thing with nitroprusside is it has a side effect like cyanide poisoning, so be aware in patients with kidney disease. And if you have a patient with withdrawal symptoms or a patient that is being agitated, we preferably use clonidine, which is a central alpha-2 agonist. But be aware not to use this medication in patients with hypertensive encephalopathy because you don't want to sedate them more. And to divide the medications that we use in Germany, for outpatient setting, as mentioned, urapidil, nitrates, clonidine, or loop diuretics. In inpatient setting, something like esmolol, nitroprusside, or enalaprilat. And then also now talking about some definitions that we had. So for resistant hypertension, this is basically defined as the failure to achieve goal blood pressure while receiving a free drug regimen at optimal doses that also includes a diuretic. And as you already mentioned, we can have common causes like obstructive sleep apnea, use of drugs, substances like cocaine, amphetamines, oral contraceptives, or immunosuppressants like cyclosporin, also primary hyperaldo or renal parenchymal disease. Less common causes are FEO, Cushing, renal artery stenosis, and now also talking about the terms that we had. So for the hypertensive crisis versus, so the term hypertensive crisis includes both hypertensive urgency and emergency. So first of all, hypertensive urgency is defined as acute significant elevation of the blood pressure, typically with a systolic blood pressure greater than or equal to 180 and or diastolic blood pressure greater than or equal to 120 without any sign of end organ damage. And before going to hypertensive emergency, I wanted Jess to comment on the term hypertensive urgency.
Yes, I will make this very quick because I want to first of all apologize and thank everyone who's still on here. I know we went over, so I apologize, but as you can see, hypertension is a very illustrious conversation. But so hypertensive urgency, unfortunately, is like actually coming out of favor. The term itself, the urgency, people end up over-treating it and patients get complications from over-treatment. So the term hypertensive urgency is kind of falling out of favor. So I want you guys to reframe your thinking of like, okay, so is this patient, that's why I made that poll question the way I did, is does this patient have hypertensive emergency, yes or no? And if it's yes, then that patient needs IV antihypertensives and needs to go to the hospital with a step-down unit or ICU level type of care. Versus if this is not hypertensive emergency, okay, then you have time. Then you can restart their medications if they have high blood pressure already, or if or add or increase the dose. So just wanted to put that caveat on there because I know we put it in our presentation here today, but I just also want to put that out there. The hypertensive urgency is slowly falling out of favor.
And exactly as you already mentioned, hypertensive emergency is basically the same definition as urgency plus sign of end organ damage. So that would be also everything from my side. Thank you so much for this amazing session. I would now ask, is anybody having any remaining questions, or Jess, do you have anything to say?
No, I just want to say thank you to all who stuck around, and I hope this was an educational experience for everyone. And again, this is my first time facilitating, so any and all feedback would be wonderful. You all know where to find me. Okay. Thank you. And Deborah, you can take away the teaching points. I just want to say a couple of thank yous. Thank you to Shema for being a great co-host, for Yusuf for guiding me through how to facilitate this, and for Sarah for doing just an amazing job of facilitating with me here today.
Oh, this was a amazing session. I tried to capture all the pearls, but was a lot. I hope I did a good job. I will try to go from some pearls from each case. From the case one, we had like the great pearl that Jazz said that the aldosterone and renin radio can be false negative in case the patient have a low salt diet, a pregnancy, if the patient uses spironolactone or AC inhibitor or ARBs. And the case two, for me, the great pearl is that like in the case, on this case that the patient have like the parent ganglioma, we had to reduce the systolic blood pressure less than 140 milligrams and for the first hour, and avoid like the beta blockers at initial, and then we have to treat with that can lead to unopposed the alpha adrenergic. And then the case three, for me, the great pearl was like the patient, like I thought this case, the patient had like an emergency hypertension, then just teaches that the patient didn't have, and a high blood pressure can cause on this patient like nausea, vomiting, and some headaches. I think this was the three major points that I took from the case, and thank you all for this amazing session.
Thanks, everyone. Have a great day.
Thank you all. Bye.